Good morning, everyone. We're glad to have you with us this morning for our third episode of the Let's Talk About OMM research series. Today's episode is a journal club. It's our first journal club episode, a session, however we want to word it. And so I hope you all had the opportunity to read the article. And so our presenter will be Dr. Brian Degenhart. And after he presents, the article, we're going to have hopefully a lively discussion about the article and what it said and so I am going to share my screen now. So just some quick business. So as I said, this is our research journal club program today. We will have a discussion forum available on the website as soon as I can get that posted when we're done. For those of you who are requesting CME credits, we have these learning objectives for the entire Let's Talk About OMM research series. So if you want to get your continuing education credits, you have to complete 3 steps. The first is that you must, in the Zoom chat, put your first and last name so that we can verify that you're here. You will receive a physician attestation form, and you will receive a evaluation survey. And despite the fact that this says the instructions were sent to the email you provided, they haven't been sent yet. So I will send that as soon as the meeting is done. Just about the program, it's accredited by the American Osteopathic Association. The ATSU is accredited by the American Osteopathic Association. Disclosure policies, we will disclose any conflicts of interest, and each presenter will do so as well. And the steering committee has no conflicts of interest. If you have any questions about the continuing education, you're welcome to contact me about this particular program. And if you have any questions about the continuing education in general, you can contact Jan Baum at A.T. Still University. So without further ado, I'm going to turn the time over to Brian Degenhart, who's going to talk about short-term effect, the article Short-Term Effect of Osteopathic Manual Techniques on Respiratory Function in Healthy Individuals.
Brian, you're muted. It wouldn't be a Zoom session if someone wasn't muted on the panel.
Okay, how about now?
Much better.
Perfect.
Okay, very good. One more. Turn that off. Okay. So once again, good morning. And want to welcome everybody to our first journal club. One of the important parts of this journal club, because we're not sure how many people have had a chance to participate in a journal club before, is to help everybody understand the process of doing a journal club, because we're hoping that our future journal clubs are going to be run by everybody who's on the program this morning and those that will be joining us in the future. We'll have the opportunity for people to sign up for future to present for future journal clubs. That's part of how we want certainly our network to continue to develop its skill set. We'll go on to the next slide. Okay. All right, so I don't have anything to disclose in regards to conflicts of interest with this presentation this morning. Okay, so we're going to go back a slide to, there we go. Okay, so the purpose of a journal club, there are three. First is to teach and to develop critical appraisal skills, and that's for all of us. And it's something that is not just occurs at any particular time during one's career. This is something that's just an ongoing process. And a journal club is really helpful in developing and improving our critical appraisal skills. It is also, the journal club is to increase our exposure to a rapidly evolving medical literature. The amount of literature that is being disseminated now is beyond comprehension. And for us to stay on top of all of that is just not realistic. And certainly we're not expecting that this journal club is going to make a significant impact on that, because in the end, we are only going to be having about 4 of these journal clubs a year. But this does help us to highlight some of the most important articles that are coming out, that are most relevant for the work that we are doing. And then once again, help us to get a greater understanding of how that research was done, to be able to critically appraise it. And then from that information, develop more informed clinical practice, since that's really our primary function as in our careers and our involvement in the practice-based research network that we have is our clinical practice. Okay, so journal clubs are designed to help facilitate better knowledge and literature awareness through group discussion with peers. And so our discussion is going to be really important. So feel free to unmute or to post something in the chat if you have a question as the discussion or as the presentation occurs. All right, go to the next slide. So as the presenter, my goal, and for those that will become presenters in the future, our goal will be to communicate the essential information about the study in a concise, mostly standardized format that is easily digested by the listener. So that is what I hope will be able to be accomplished this morning. And the citation on the bottom of this slide is a really good summary of how a journal club should be performed. Okay, we'll move to the next slide. So the format for the journal club. So first is to describe what attracted you to the paper. Every person who's the presenter has the luxury of determining which paper they are going to present. You want to then explain how you came across the article. So what was your search method to find it? Because that will also help us develop our skills as a group to be able to find relevant literature. Then it is looking at what type of question was asked, the type of study that was done, and where it was done. And then to state the research question and why you feel that it was important. We'll then look at a brief background and then details on the patients, the intervention, the comparison, and the outcomes. And that's the mnemonic of PICO is a very commonly one used in the development of grants, making sure that a grant is well constructed. It's also very important in manuscripts, and then in the presentation of the manuscripts in a journal club. After presenting the PICO, then we look at summarizing the primary results. It doesn't necessarily require all of the results to be presented, primarily those that are relevant in answering the research question and that seem most relevant to you as the presenter. Then you will then evaluate the article for its basic validity, and then have discussion on whether or not the results can be applied to our patients in our clinical practice. So that's the overall process that a journal club is designed to do. And so I'm going to go ahead and begin to present this week's journal. Is this a time to address any questions? Are there any questions about the overall purpose and the presentation of a journal club before we head into this? Okay, very good. Thank you, Jeff. All right, so I ended up choosing this article from PLOS, The Short-Term Effects of Osteopathic Manual Techniques on Respiratory Function in Healthy Individuals. These researchers come out of Poland. They are DOPTs there. And going on to the next slide. So why did I choose this study? First of all, it was just recently published. It also was hopefully easily accessible. I think that's one thing that's really important for future presenters, to make sure that when you choose a study, that it's something that everybody can get access to online. So to have open access article is important. This study was a very common format for osteopathic research, applying a technique or a series of techniques to a particular population to see if that technique had any particular results. And I can say that this is also an area of my personal interest. I've certainly published with collaborators in the area of pulmonary function tests. And this is an area of work that we're going to be expanding at A.T. Still Research Institute as well. So that's why I ended up choosing this study. Okay, so why is this study significant? Well, certainly everybody knows that breathing is the most vital biological function of the body. And when we stop breathing for a very short time, there are significant consequences. So to be able to breathe and to optimize breathing is important. It is holds the sixth place among the most common causes of death in the world. These are the various diseases that influence our ability to breathe. And it is expected by 2030 that will be the third highest common cause of death. There are many types of symptoms that are also associated with pulmonary diseases. And those not only include shortness of breath and coughing, but also exhaustion, pain, depression, and anxiety. And so these are things that are commonly presented by the patients, by the clients that we see in our office. And so once again, it's really a relevant area for us to look at. Now, we can look at just outside of what they reviewed in that effective therapy in a respiratory system clearly has global significance. As we're dealing with the current pandemic and as a respiratory, generally a respiratory system disease, effective therapy is certainly obviously critical. And effective therapy on the respiratory system has really been key to osteopathic history. Early on in the profession in the 1918, the whole flu pandemic at that time, and the use of OMT to treat those patients, really for a century became a focal point for demonstrating how the use of the hands can influence the physiology of an organ system. And so, once again, I think all of these reasons are why this particular study is important for us to look at today. So what was their research question? The research question was to assess the influence of osteopathic techniques on breathing. And so in some respects, it wasn't a question. It was, more of an observatory type of purpose for their study. When you're doing research, it's often really important to evaluate, to have hypotheses as part of your study. So that was one thing I did not see in this particular article. If you want to go ahead and forward, there you go. And they certainly very easily could have made a statement that if the use of osteopathic techniques would improve spirometric parameters and be specific regarding what those parameters were. They didn't also have a very thorough review of the literature. They missed of several osteopathic studies that used pulmonary function tests, spirometric measurements as outcome indicators for OMT. And so we certainly, when we are disseminating our work, we want to make sure we are certainly acknowledging the work that has been done before and how you are building upon that in this current study. And then lastly, there was no consideration of the osteopathic manipulative therapy model with pulmonary physiology. So in addition to the hypothesis, which was missing, which was kind of implied that the use of OMT was going to improve these various outcome measures, that should then be followed by some type of physiologic rationale for that you're really testing. And so those were some limitations in this study's outline of their research question. Okay, so next we're going to look at the PICO, looking at the population, the interventions, outcomes, and so forth. And so they had 30 healthy adult volunteers, equal number male and females from the age of 18 to, I believe it was 48. Sorry, that's missing on this slide. 15 individuals were randomly assigned to an experimental group and 15 to the placebo group. So the experimental group had experienced 3 types of techniques. One were thoracic thrust techniques, which were manipulations focused to the vertebral joints and ribs. The next technique was a sternal pump technique. And then lastly was a technique involving the stretching of the diaphragm. So that was the experimental group. The control group, they had their patients, their volunteers lying supine, and they performed soft tissue to the masseter muscle, to the cheeks of the face. And they gave a rationale to the volunteers in that group so that there was some, potential placebo impact that could help to maybe augment the outcomes. So in the end, they chose a population that were healthy, that were asymptomatic. But there was really no indication regarding somatic dysfunction. And I think in general, there could be an assumption that based off of the healthy population, that we would have considered that the level of somatic dysfunction with whatever was present would be subclinical and not very important. Okay, so we'll go on to the next slide and look at then spirometry. What we're going to do is, I'm not sure how many people has seen spirometry. So we're going to see, we have a very short video just so you can all make sure that you understand what that's all about.
Joan, today we're going to assess how your lungs are working. To do that test, we'll be using this equipment called a spirometer. What we're going to measure is how much air you can blow out and how fast you can blow it out. So I'll be encouraging you to do some very big breaths in and out today. To do the test, sometimes it can make you feel a bit dizzy or lightheaded. So we'll be doing it sitting down in the chair with your back nice and straight and your feet flat on the ground. We'll also be using a nose peg on your nose, and that will just ensure that all the air is coming out through your mouth to be measured. Get you to hold this mouthpiece there. You'll have, when you place it in your mouth, you put the teeth and the lips over the end, a good firm seal with your lips. So I'll ask you to have a really big breath in, pop the mouthpiece in, and then blow out with all your might, as hard and fast as you possibly can, for as long as you can. Then I'll ask you, still with the mouthpiece in, to have a big breath in. I have criteria that I have to meet to ensure that we're going to get accurate results. So we'll need to do at least 3 blows, and as long as I've got 2 blows that are repeatable or consistent with each other, we'll be able to accept those results. Now, before I start, I need to ask you if you had any of your puffers today. No, that's great. We can go ahead and do the test. If you had them, we just need to make a note of the time that you last took it. So, Joan, we just need to pop this nose peg on your nose. A bit uncomfortable. You right there? Good. And if you just hold the mouthpiece there. And when you're ready, I want you to have the biggest breath in you possibly can. And mouthpiece in and blow. Push, 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 push. Keep going, keep going, keep going, keep going. That's fantastic. All the way, all the way. Biggest breath in and relax. Well done. Good effort. That's looking really good.
Okay, thank you, Jane.
So we need to do another breath now.
Okay, so you can see that it's a very simple piece of equipment. It's something that can very easily be done in a clinical setting. It has, relevance for a practice-based research network to be aware of the spirometry. As we saw in the video, spirometry is used to measure how much air that you can inhale, how much you can exhale, and how quickly you can exhale that air. And so it generates a variety of outcome measures. And one is called the forced expiratory volume. So the FEC is pretty much how much air can you push out over a certain period of time. And so that can be done at different periods. So that the forced expiratory volume subscript 1, which is our second measure there, is how much air the person was able to push out within 1 second. And there's FEV2 and 3, so it can be done at different time frames, looking at the forced expiratory volume over time. When we have the person, as we saw in the video, completely blow out all the air that they have in their lungs, that's the forced vital capacity, or FVC. The peak expiratory flow, that means that's the fastest you can blow air out in that whole cycle of expiration. Generally, that occurs within the first 200th milliseconds. So very early on, as we push that air out, that's where that peak expiratory flow is measured. And that's one of the measurements that's critical in our article today. So I'll make sure that people understand that. And then lastly, it's the total lung capacity. How much air is in the lungs? And we get that information in that very big, deep inhalation that the patient did at the end of the video. Okay, so here is what the data will look like that this barometer will produce. And so the blue line here is the amount of volume in liters of air that has been blown out over time. And so that's what the line shows. And in a healthy, normal patient, which is what we are working with within this study, we see a very sharp increase or a large amount of volume going out of the lungs very early on, where we see the peak expiratory flow being measured. We see the forced expiratory volume at 1 second. And then we can see that it peaks out around 2 to 3 seconds, and it remains kind of stable out to a 6-second time frame. When doing spirometry, we really want a person to blow out at least 6 seconds to have a good valid test. In this other graph, we're looking at a person with obstructive lung disease. So this could have been a smoker and this is how their spirometry measurements have changed. We can say that the airflow is significantly slowed down, that there's not a very rapid explosion of air coming out that would be part of their peak expiratory flow. We see that within 1 second of time, their forced expiratory volume is significantly reduced from 4 liters down to less than 2 liters. And so this is how we're seeing that the air is not coming out as easily or as smoothly as possible. So there's obstruction within that pulmonary system. So this is what spirometry allows us to see. So in their study design, actually, I misspoke earlier. I said that they had equal number of males and females. No, in this particular study, they only had healthy women as part of their study design. So you can see all of the things that they ruled out to make sure that these volunteers were healthy, that they had no pulmonary problems whatsoever. Okay. So what was their protocol? So as I mentioned earlier, there were 3 parts to their protocol. One was a spinal thoracic thrust, of which I felt was really poorly described. And in the modern world, even though a lot of people might know what that is just because of their training, in the world of science, there are a lot of fields that are going to be interested in the outcomes that we have. And so we have to be descriptive of what is being done. In their methods section, there was no description of where it was being done, just that it was in the thoracic area. In their discussion, they did have one sentence that indicated that it was focused from T1 to T5 only, but it didn't say whether they did every single vertebral level, whether it was just based off of what they localized as being dysfunctional segments. And that would also then be true for rib angles, because they did say that this was kind of trying to address both intervertebral dysfunctions as well as effects of ribs into the articulations with the thoracic vertebra. With the sternal thrust, I found this interesting because this is certainly not a technique that is commonly taught within the American osteopathic system. Here they had a patient that was supine. The clinician stood above them with their hands overlapped directly on the sternum. So more like doing CPR versus when we do thoracic or pumps in the United States, it's really more out on the ribs themselves, not on the sternum. And so they applied force on the sternum. It was unclear what level of force that they were applying. And they applied that force during exhalation. So basically trying to augment the air going out of the lungs through the pressure on the sternum. They performed it 5 times. And at the last 2 times they did it, they did recoil. So I'm not sure, they didn't really describe what recoil meant. I'm assuming that means that as a person breathed in, they removed their hands that allowed for a certain amount of recoil from inhalation. But that is only assumption on my part. The last technique they did was the diaphragmatic stretch. And here they placed their hands underneath the lower part of the costal borders of the rib cage. And with inhalation, they augmented the movement of the ribs. And then with exhalation, they inhibited or stopped rib motion during exhalation. So there was definitely a building up of tension in that lower rib cage and diaphragm in hoping to produce some type of therapeutic effect. And that was repeated several times at different points along that thoracic or rib border. So that was the intervention, the OMT protocol. For the control group, they had the patient supine. They identified the masseter muscle. And while the therapist, the clinician was at the head of the table, they performed rubbing techniques along the masseter muscle, both longitudinal and friction directions along the masseter until tenderness and local spasm was decreased. And I thought that was kind of interesting because first of all, as I do it on myself, there's no tenderness or spasm present. And if these are healthy normals as they screened in their recruitment, then having tenderness and local spasm would not have, from my perspective, have been expected. So how could they have determined that as a time for stopping that particular aspect of their protocol? Okay, so on to the outcome measure. As they first did basic spirometry, as we had just seen, to evaluate the various spirometric measures. They had 3 tests done so that they were repeatable to make sure that they were valid assessments. And then the participants' best single trial, those measurements were the ones that were used for analysis. So here are the results. In table 1, this is looking at the baseline measurements. And here we can see that there were no differences in the forced vital capacity, the forced expiratory volume at 1 second, or the peak expiratory flow. These were the three measures that they reported in their study. And we can see, looking at experimental and placebo groups, that the p-values were 0.18 or higher. The positive expiratory flow is the one that was certainly lowest. The other two were around a p-value of 0.5 or better. Now, if we then look at table 2, which looks at the comparing before and after within group. So looking at the OMT group before versus after, and the placebo group before and after, we see that first of all, we'll talk about the placebo group first. We can see that there were no statistical significance between them. There was certainly a bit of a change with the forced expiratory volume 1, but once again, not close to a 0.05 level whatsoever. So everything would indicate that there were no changes as a result of the placebo intervention. When we look at the experimental group, we can see that the forced vital capacity was at a 0.07, which does not meet the criteria for statistical significance. We see with the forced expiratory volume at 1 second that was a 0.14, and then for the peak expiratory flow, a highly significant change between baseline and the post manipulative therapy. When we move then to the third table, where they're comparing the placebo versus the experimental group, here we can see that there was no change between those groups after the intervention. And so that is kind of interesting, and may seem kind of confusing, how you can have, no differences at baseline. You see differences occurring before and after treatment within a group, but then afterwards, you don't see any difference between the groups as well. And so Jane Johnson produced our next slide to help us understand what's going on here statistically. So here, when this is called a box plot, and with the box plot, the majority of the data falls within the box, and the line goes out to the least and the greatest, the maximum value for that particular area. And so here we're looking purely at the peak expiratory flow measurement, where they saw the statistical significance. And we can see within the experimental group that before treatment and after treatment, there was the statistical significance. But we can see that there's significant overlap between the data within that group from before versus after the OMT. When we look at before versus after in the placebo group, we see that there's really, no change in the box plot whatsoever. And when we look at the after boxes for the experimental versus the placebo group, once again, they look very, very similar. Some slight changes regarding the median and the minimum value. But once again, we're seeing really very little change going on between the placebo group and the experimental group, although they did report a statistically significant change in the peak expiratory flow measurement. So one of their conclusions was, or their purpose was to obtain a significant positive effect. A combination of manipulative techniques, such as manipulations of the intervertebral joints and costovertebral joints, combined with soft tissue techniques that included a diaphragm stretch, releasing myofascia of the cervical and thoracic regions, and a sternal pump or visceral manipulation should be used. And so this was their conclusion based off of the data that we just saw. And I think that this is really significantly exceeding both the research question, the design, as well as the results that are associated with this article. And we will engage this in discussion in a moment. And so what are the limitations that I've identified? And certainly some of these they identified as well. So first of all, a major limitation is that there was no proposed mechanism upfront as to why they would think that the peak expiratory flow would be expected. They had no proposed mechanisms for how changing or ribcage biomechanics would impact change, whether it's just due to the somatic system or through a neurogenic regulatory changes associated with autonomic factors that we typically attribute to these types of techniques. Another limitation, and I think we'll need to discuss this, is that they only used, they chose to only use normal, healthy adults. And they did not report any examination of somatic dysfunction to determine or to demonstrate whether the techniques that were performed were relevant for those particular patients. And so once again, I think when we talk about osteopathic manipulative treatment versus osteopathic manipulative therapy, one being more potentially a recipe-driven protocol versus one that is specific for patient findings, I think this may be a factor that brings out limitations for this particular study. They recommended that in the future that they wanted a larger population, but one of the advantages of this particular study is that there is now data that could allow us to do some power analysis for these particular outcome measures. So the outcome is beneficial for future research. They wanted better definition of overall the cohort and sub-cohorts. I think, as I mentioned, better establishment of hypotheses that hopefully maybe with this study they might be able to develop a better definition of the techniques. And I think one thing that often we neglect within osteopathic research is to bring in somebody that is a content expert within the measure, within the instrumentation that are being used, or within the field of the physiologic parameter that's being done. And so here, having somebody that was a pulmonologist, somebody that has expertise with spirometry would have been very helpful to guide the methodology and interpretation for this particular study. So from their conclusion that they said that there was an indicated that peak expiratory flow may be considered a reliable marker for measuring the effects of osteopathic manipulative treatments targeting the respiratory system. From the review that we did, I'm hoping that you would be critical of that particular conclusion. First of all, this is not a study of reliability, and that the results were really quite slim to determine changes before and after treatment. So I think that conclusion is not very supported by the outcomes. From my perspective, this was not a study of reliability, but to demonstrate that a test may be sensitive enough to identify biomechanical changes of the rib cage and are the neurologic or neurogenic regulatory changes of lung physiology that could be secondary to OMT. So that is my presentation of our first article for DO TouchNet's Journal Club. I'd like to now open up a time for discussion.
Brian,
And
you do
these
have-
are some evidence-based references that you can look at as well for further review.
You do have 2 questions right now in the Q&A pod here. We've got, to which of the 5 columns of outcomes do the p-values refer?
Okay, so I think we go back to one of the tables. I'm assuming that's in regards to the table.
I can just answer that if you'd like.
Okay, please do.
They refer to the median, so comparing the medians, whether the medians were different. The within group comparisons look at the median change from pre to post. The between group comparisons just compares the 2 groups on the median.
Okay, and we've got another question here. They say that they included 30 male and females, whereas later the exclusion criteria, they explicitly excluded males. Did they not find any male participants, or did they only find unhealthy men?
No, this is a sign of an incompetent presenter. I was incorrect in that earlier slide that talked about men. This study was designed for only females, and so that was my. I am just in study designs in general. If you're only going to focus on a particular component of the population, you need to have a good rationale. It's important to have a rationale for why you're excluding people, and so I just made an assumption that they used both sexes, and it was so that I never changed that earlier slide. So my apologies.
But it does say in the abstract that they had 30 healthy males and females. So.
Well, thank you. I knew there had to have been a better reason. I'm going to accept the outright, bit for that, but it was not addressed in the article about men. They just talked about the exclusion criteria and men being one of the exclusion criteria. Male.
Okay, and we have Marcus here with his hand up. Let me pop. There you go.
Hi.
Hello.
So yeah, that's just what I wanted to say, that you did not do anything wrong. It says it right here. So thanks, Jane, for cleaning it up. But while I'm unmuted, what would you think? Like, isn't that a peer-reviewed journal where they published? Shouldn't like different people pick up the things you just mentioned and keep them from publishing, not because they are generally bad people or this is generally bad research, but maybe this is questionable research or does not contribute any value to our profession. So I don't know, maybe this is a little bit of off topic, but maybe you can shed some light on how this process usually works, because it really, like I read this for I think 5 or 10 minutes and immediately took up my phone and wrote to Jane, because I thought, like, am I doing something wrong? Because I think this article, and I mean, no offense to the authors, but it doesn't seem really good.
Yeah, thank you for bringing that out. This wasn't my initial choice. I was going to, the one that I had originally thought of was one that I know would have been very much a premier article. But a lot of times our work gets into, lower level peer reviewed journals. And right now there are so many places where peer reviewed journals exist, but they are really, part of a way of making money. And so the review process is not as stringent as what is really driven by the scientific community versus just a publication, dispersal community. So as we choose our articles in the future, this is an important point that we need to look at. One, we have to be able to have access to it. And there are many highly regarded, rigorous periodicals that have that we can choose from. But once again, if you see something from the very beginning that says, "Wow, the reviewers didn't obviously review it quite well," that's just an indication that that's a level of a peer-reviewed process that really we should probably avoid in our work here.
Thank you.
Okay, so we have another question here. More of an observation. This was going to be underpowered from the get-go. Osteopathic intervention in an asymptomatic population would be anticipated to show limited changes.
Yeah, so this is an issue. I'm going to let Jane talk because she has seen many studies through her 20+ year career as a statistician and methodologist within this field. So we have already talked about it, but I'm going to let Jane address that.
So I told Brian in my professional medical opinion as a statistician, it is curious to me. There seems to be a lot of research done on healthy populations in the osteopathic profession, and my simple analogy is, if you give an aspirin to someone who doesn't have a fever, you don't expect their body temperature to reduce. And so if you're doing osteopathic manipulation on people who don't have somatic dysfunction, then do you really expect there to be a change? So that was just,
Yeah. So in this case, do we expect that OMT is going to allow the balloon of our lungs to expand, a bit more, and is going to change the forces of expelling that air when, once again, their body is healthy and normal? And so once again, that's a recurrent design issue that I think we need to screen out with as we choose future articles and as we prepare our future research studies, once again, that we are choosing the right population for the question that we're asking.
And you got an absolutely agree with you, Jane, in the Q&A pod there. Another one here is, I find it interesting that smoking wasn't included as an exclusion. However, having been in Poland, they might not have had any participants given how many folks smoke. Another one here, fully concur that the clinical significance of the hypothesis was in question, and I couldn't answer the question as to why the paper was important enough to publish. Followed up by, an OMT doesn't change us into supermen or women. I think that was following up on your last comment there. And I have, it's like Dr. Brooks with a hand up here. So here we go.
I have a couple of comments. First of all, Brian, thank you for an excellent review and a great start to this process. I too was distressed by this paper, but I think perhaps the problem isn't so much that it was a study that shouldn't have been published, but it should have been so critically reviewed that the conclusions and the speculations and the discussion should have been eliminated. In other words, there's probably very little data that isn't worth reporting. The problem I find is what people do with the data. And so there might have been some data that was worthwhile here, but it should have been very, very, very much more narrowly interpreted, I think. And so that was one comment. The other comment is I've been interested in chest compliance for some time, although I'm not up to date on the literature. And in the pulmonary medicine world, there's basically the assumption that the mechanics of chest wall are a fixed variable. In other words, they're not a variable. And so I appreciate your slide, although it was non-committal, one of your concluding slides. Well, it could be mechanical or it could be pulmonary. And the fact is that when we breathe, it is a both and situation. In other words, you have to have a healthy lung and a healthy mechanical system. I think it's a great opportunity for our profession to start to raise consciousness about this and start to tease this out. And even in a setting like I'm guessing these physical therapists were working in, which probably didn't have, the kinds of resources that we would hope they'd have for more sophisticated outcome measures. But the simple act of measuring chest expansion with a cloth measuring tape is a way to start to discriminate the mechanical properties of breathing from the total pulmonary function that's then measured with spirometry. So I know you are working on much more sophisticated tools at Kirksville, but I think it's something that others could consider and is really foundational, in addition to all the other critiques that you appropriately offered, for us to be able to say there's actually a biomechanical change or not that might then be mechanistically linked to what actually happens when you breathe. So those are my two comments. Thank you.
Okay, we have one other hand up. Sergio, I think we got you unmuted there.
Sergio, you might unmute yourself.
Sorry. Yes, it was the case. Thank you. Sorry, guys. I have a few comments. First, congratulations, Dr. Brian Degenhardt, for your great presentation about this article. And as I am living in Europe, I know the European mentality from the osteopaths who are studying osteopathy in Europe. So most of them are physical therapists at a basis. Some are doctors, but the most of them are physical therapists, and they are using only techniques without the background, the scientific background. And they think that if we use a technique, we can implement the system. Because maybe they read some books of Dr. Steele, but Dr. Steele was using that the osteopathic techniques of sick person who has lung problems and not a person who are healthy. If you want to start a discussion about what are the osteopathic technique doing on the physiology, then we need to do it maybe first on healthy people, and then to see if we do it on healthy people, what can we expect about it? But it's true, if we do it on healthy people, we have to always to have a comparison, a control group who says, if I don't move this rib, and I ask only the patient to breathe, to do a big inspiration, it won't, it will fix it on its own. Who knows that, if it is the case or not? That when we practice that osteopathic medicine on our patient, osteopathic manipulative treatment, we know what we want to reach. But as Jane said, we cannot practice osteopathic medicine on healthy people without somatic dysfunction. It's like taking an aspirin for someone who has no headache or fever.
Okay. Well, thank you.
Sorry, last point. No surgeon would do an operation to see what is it if I do a surgery on that, if I don't take off an appendicit for someone who has no appendicity. An appendectomy, sorry, you have understood me, you know, I don't take a surgery for someone who has no a bowel problem and abdomen, very pain in the abdomen, like an appendectomy, appendicit. I don't take the appendicit away because I want to test surgery about about the colon. So there are some, we have to ask ourselves what we want to reach. Dr. Steele did a lot of wonderful techniques, but they don't have been, they have been improved during the years, but we don't have search, because only based on the somatic dysfunction, but never on what can cause on the physiology these manipulative techniques. Thank you. I know it was a lot of, sorry.
Thank you so much. I'm afraid our time is up for live discussion, but I really hope that we are able to continue this discussion about this article on our website forum. I hope to have that open and ready for discussion this afternoon. And I'll just thank Brian for his presentation, and remind you of our next Let's Talk About Research, OMM Research episode, which is scheduled for January 15th. And that will be a director update about the activities of DOTouchNet and what we're doing. There will not be continuing education credits for that session, but when we're back in February with our webinar, we will have that available then. So thank you so much.